Picture the scene. A really bad accident. First responders show up and they find someone with terrible injuries, no pulse, and they're not breathing. Now, for decades, the reaction was automatic. Start chest compressions. But what if that very first gut instinct move was actually the wrong one? Today, we're going to break down a protocol that flips that whole idea on its head. Okay, let's just jump right in with this. This question right here, it seems to go against everything we've ever learned about saving a life. If a heart stops, you push on the chest. It's that simple, right? Well, in the very specific world of traumatic arrest, the shocking answer is chest compressions. And understanding why that is, well, that's the key to this whole new logic of survival.
So to really wrap our heads around this, we have to get one thing straight. Not all cardiac arrests are the same, not even close. You got your medical arrest. Think heart attack. That's a pump problem. The heart's electrical system just goes haywire. So yeah, compressions make perfect sense. You're basically being the pump. But a traumatic arrest is a totally different animal. It's not a pump problem, it's a fuel problem. The patient has lost a catastrophic amount of blood. The tank is just empty. And that brings us to the official name for it, traumatic circulatory arrest, or TCA. The most important thing to realize here is that the heart itself is probably working just fine. It only stopped because it literally had nothing left to pump. The whole system collapsed because of a massive leak. So pushing on a perfectly good pump that has no fluid in it, yeah, that accomplishes absolutely nothing.
Okay, so let's put ourselves in the boots of those first responders. They arrive on a chaotic scene, but their training for this exact situation has to kick in. And the very first priority isn't about how to start treating the patient. It's about identifying who this patient is. Are they the right person for this very specific protocol? And this is basically the mental checklist they are running through in a matter of seconds. First, is the cause clearly from a major injury? Second, did we, the EMS crew, actually see the patient's heart stop? That's huge because it tells us how long the brain has gone without oxygen. And finally, are the injuries just so devastating that survival is impossible? Only if the patient fits that very specific window does this protocol even begin. And getting this initial decision right is, well, it's everything. Because if the paramedics think the arrest was caused by something medical, like maybe a heart attack caused a small crash or it's a drowning case, they go down a completely different road. They switch gears and go right back to the standard playbook of CPR and defibrillation. Choosing the right path in those first few seconds changes everything. And here it is. This is the single most mind-bending instruction in the whole protocol, pulled directly from the guidelines: withhold compressions. Just let that sink in for a second. Instead of jumping on the chest, crews are ordered to do a whole bunch of other things first, all at the same time. So what are they doing instead of compressions? They're attacking the real problem. Job one is to stop the massive bleeding. We're talking tourniquets, packing wounds, whatever it takes. At the same time, they're pushing high-flow oxygen and making sure the airway is clear. And this is key, they're getting 2 big IV lines started to begin pouring fluids back into that empty system. It's this incredible, coordinated burst of activity all aimed at fixing the cause. I mean, it's so important we're just going to say it again on its own. Compressions, wait. In a world where push hard, push fast is drilled into everyone's head, this deliberate pause is the complete game changer. And the logic behind it all comes back to this one perfect analogy. Trying to do compressions on an empty heart is like trying to start a car that's out of gas. The engine could be flawless, but it's not going to do a thing. The first job of the mechanic, or in our case, the paramedic, is to plug the hole in the gas tank and start pouring some fuel back in. Now, this protocol also has a really critical checkpoint built into it. After they've done all those things, plugged the leaks, started refilling the tank, the crew stops and reevaluates. If there are still 0 signs of life, only then do they start to consider that the patient might not be savable. It's all about giving the body a fighting chance to respond to the treatment first. Okay, so that flurry of on-scene work is done. The patient is packaged for transport, and now it is a flat-out race to the trauma center. But the life-saving care is far from over. It just moves into the back of the ambulance. So that raises the next big question, right? After all that work on scene, what happens if the patient is still pulseless as they're speeding down the highway? What's the move now? And this is the moment. Now, and only now, do compressions finally enter the picture. Because now there's actually some fluid, some volume back in the system. Pushing on the chest can actually do something. It can circulate that new fluid and get precious oxygen to the brain and organs. It was never about if compressions work, It was about when. While they're en route, paramedics are also pushing a crucial drug called TXA. The easiest way to think about it is like a bodyguard for your body's own repair system. See, when your body forms a clot to stop bleeding, other parts of your system naturally try to break it down. TXA just steps in and tells those parts to back off, helping those life-saving clots stay strong and do their job. And what's really incredible is just how tailored this care is, even in the back of a moving ambulance. The dose of TXA isn't a one-size-fits-all thing. For adults, it's based on their level of shock. But for kids, it's calculated very carefully based on their weight and their blood pressure. It's just a perfect example of smart, data-driven medicine in action. During that transport, the goal with the IV fluids is also super specific. Paramedics are trying to keep the patient's blood pressure just above 70. Now, the goal isn't to get it back to normal. Pushing it too high could actually blow out the fragile clots they're trying to save. It's about keeping it just high enough to perfuse the brain and organs until a surgeon can take over for good. Look, if there is one single thing that you remember from this entire explainer, please let it be this. This is the fundamental truth that drives every single decision we've talked about. You can't pump an empty heart. So let's just tie it all together one last time. This new logic of survival is a simple 3-step sequence. Step 1, stop the leak. That means controlling the bleeding above everything else. Step 2, refill the tank. Push those IV fluids hard to replace what was lost. And then, and only then, do you move to step 3, restart the engine by using compressions to circulate what you've just put back. What this all boils down to is that a situation once considered almost 100% fatal now has a playbook. It's no guarantee, of course, but it transforms what used to be a hopeless scenario into a calculated, physiological fight, giving people a real fighting chance to survive what should have been unsurvivable injuries. Ripping up the rulebook on something as basic as CPR really shows you the power of asking not just how, but why. It forces us to look beyond the procedure and zero in on the actual problem. And it kind of makes you wonder, doesn't it? Now that you get the logic here, what other piece of conventional wisdom in medicine or anywhere else is just sitting there waiting for somebody to ask the right question?